So here's what I'm going to be discussing, the pregnancy problems in the UK, factors leading to low vitamin D during pregnancy, the mechanisms of vitamin D, the effects of low vitamin D on the mother and on the fetus, recommendations, and then mention my 100 health conditions study. So here's what I found related to health pregnancy problems might be related to vitamin D deficiency in the UK. Anemia turns out affects about 12% of women at the first trimester, rising to 50% in the third trimester. Cesarean section rates range anywhere from 13.6 to 31.9%. I'm not sure this is UK particular, but in general, say in Europe and the United States. A paper in the United States found a 6% rate of gestational diabetes. Bacterial vaginosis was found in one study for 3.5% of the women without symptoms. One study found that influenza-like illnesses affect about 2% of pregnant women. Preeclampsia rates, I think this UK is about 5.2 per thousand. And sepsis results in about 1.13 deaths per 100,000 pregnancies. So the risk factors for low vitamin D during pregnancy include obesity, dark skin, covering, no supplements, long-term hospitalization during pregnancy, and the recommendation to limit fish consumption due to mercury contamination. The vitamin D mechanisms, of course, include calcium absorption and metabolism, activation of vitamin D receptors, therefore regulating the expression of hundreds of genes, increasing the expression of some, decreasing the expression of others. So this would be very important for a developing fetus to have the vitamin D receptors activated to get the right genes going. Reduced inflammation and viral effects through effects on the cytokine production. Then the effects on bacterial infections through induction of cathelicidin and defensins. And of course, effects on cellular differentiation, proliferation, and apoptosis. This is a partial list of the effects of vitamin D. There's still mechanisms of vitamin D being discovered all the time. Here is just a schematic from a paper by Shin et al. In the journal Placenta, showing some of the effects of vitamin D acting during pregnancy. In this, he says that production of 125 dihydroxy vitamin D exceeds clearance, and the levels increase, being twofold higher in the serum in women in the third trimester of pregnancy than in non-pregnant postpartum women. That's what Bruce Hollis showed this morning. Collectively, the data suggests that 125 aids implementation and maintains normal pregnancy, supports fetal growth during delivery of calcium, controls secretion of multiple placental hormones, and limits production of pro-inflammatory cytokines. So, how do low vitamin D levels impact pregnancy outcomes to the mother? These are some of the findings that I've found. Anemia, primary C-section, gestational diabetes, bacterial vaginosis, influenza, preeclampsia, sepsis, diabetes, and tooth loss. There is mounting evidence that a primary risk factor for anemia is vitamin D deficiency in addition to iron deficiency. Anemia is defined as any hemoglobin value less than 11 grams per deciliter in any trimester. In my opinion, reduced risk of anemia may be one of the more important reasons to encourage adequate vitamin D levels during pregnancy. Here is one study recently reported in Tanzania. This is a study of pregnant women with HIV. The women with low vitamin D status had a 46% higher risk of developing severe anemia during follow-up compared to women with adequate vitamin D levels. The vitamin D status had a protective association with HIV disease progression, all-cause mortality rate, and development of anemia during follow-up to in HIV-infected women. I think this study also showed that the women with higher vitamin D were less likely to pass on HIV to the fetus or the infant. A study in Los Angeles found that higher vitamin D levels lowered the erythropoiesis stimulating agent requirement for chronic kidney disease patients with anemia. A study in China found, among other things, that the higher birth weight was associated with hemoglobin concentrations ranging from 90 to 140 grams per liter, whereas lower birth rates occurred below 80 grams and above 140 grams per liter. So there is a bit of a U-shaped curve here. A study in Burkina Faso tried supplementing women with iron and folic acid and or other micronutrients, and still found that 43.2% of the participants were anemic at the end of the study. So they may have called it iron deficiency anemia, but giving them iron didn't reduce the amount of anemia, which is what this shows here. One of the things that John Cannell showed in his paper, I think in 2008 or 2009, on athletic performance and vitamin D, was at the end of the summer, athletes had much more oxygen, had the highest level of oxygen carrying capacity in their body, which meant that the vitamin D during the summer was stimulating vitamin D red blood cell production. Here's just a complicated graph indicating that as well. It's showing the iron stores at the birth, and they will decline slowly as the infant increases. And then the solid line is the reference body iron, and one can see that as time goes on, if they haven't had enough iron at the beginning, they're going to reach iron deficiency earlier in their life. Primary C-section is another important reason for vitamin D levels during pregnancy. This is a study reported a couple years ago by Merwood, Hollick et al. And they found that women with 25 hydroxy D levels less than 37.5 nanomoles per liter were almost 4 times as likely to have a C-section than women with the levels greater than 37.5 nanomoles per liter. And here's a scatter plot of the results. And you can see that it goes a very high rate, about a 30% probability of a primary C-section for those around 10 to 15 nanomoles per liter, dropping to about less than 5% at 150 nanomoles per liter. So if you have generally about, in the United States, I think it's about 9 or 10% of births are delivered with primary C-section. It seems that the vast majority of those are due to vitamin D deficiency. The total C-section in the United States is more like 30%, but 20% is elective because the doctor or the patient or the hospital wants to be able to time the delivery and get out on the golf course or avoid all-night delivery or whatever. But anyway, then I think there's another problem with once you've had a C-section, it's harder to get the health system to agree to have a vaginal delivery the second time. But I think if they were able to look at the vitamin D and whether it was a primary C-section because of low vitamin D, they might be able to realize that maybe the next time with vitamin D they wouldn't need to have a C-section. But here's just a study by Zhang et al. From PLOS1 showing that those with gestational diabetes had mean values around 27 nanograms per milliliter compared to over 30 nanograms per milliliter for the controls without gestational diabetes. Bacterial vaginosis appears to be an important cause of infertility. It's often associated with preterm delivery and miscarriage, increasing risk by 2.4 for preterm birth and 6.6 for miscarriage. The first study reporting a correlation between serum 25-hydroxyvitamin D levels and prevalence of BV appears to have been by Bodnar, 2007. And she found a inverse relationship for black women, but no correlation for white women. Another study found a vitamin D deficiency was associated with BV only in pregnant women, not for non-pregnant women. That's by Hensel et al. Now, influenza-like illnesses are an important risk for pregnancy. John Cannell wrote the first paper suggesting that low vitamin D was an important risk factor for influenza. He wrote that in 2006, and He, at that time, was a psychiatrist at a state hospital for criminally insane, and he'd been giving the patients his ward, I think maybe 5,000 IU per day. And when influenza came through the hospital that winter, his ward was largely spared. So he got to thinking about it, and he went back to a paper by Hope Simpson showing the seasonality of influenza, and thought that, well, maybe vitamin D does reduce the risk of influenza. Published paper in a British journal, and it was very quickly supported by a randomized controlled trial in Long Island with black postmenopausal women in a post hoc analysis, finding that women who took 2,000 IU per day compared to placebo had 10% as many colds or influenza cases as those on placebo, and then those taking 800 IU had, I think, a 60% reduction. More recently, there was another study in Japan with school children taking 1,200 versus 200 IU per day. Those taking 1,200 had 1/3 as many cases of type A influenza as those taking 200. There was no effect on type B influenza. So it seems that, as far as I can tell, the risk of influenza on pregnancy is raising the body temperature, hyperthermia or fever. And this is from a paper by Edwards from Australia. And he's going over what it does. And he says it causes a wide range of structural and functional defects. The central nervous system is most at risk, probably because it cannot compensate for loss of prospective neurons by additional divisions by the surviving neuroblasts, and remains at risk for stages throughout pre- and postnatal life. In experimental animals, the most common defects are of the neural tube, microphthalmia, cataract, and microencephaly, and associated function and behavioral problems. Defects of craniofacial development, including clefts, the axial appendicular skeleton, the body wall, teeth, and the heart are also commonly found. Nearly all these defects have been found in human epidemiological studies following maternal fever or hyperthermia during pregnancy. Suggested future studies include problems of CNS function after exposure to influenza and fever, including mental retardation, schizophrenia, autism, and cerebral palsy. This is Edwards, 2006. He's written several other papers on this topic. And I've seen in the recent literature in the last couple of years, say with the swine flu, that pregnant women are among those that are most likely both affected by influenza and most likely to have adverse reactions. And I'm pretty sure it's because they have low vitamin D during pregnancy. The mainstream papers say, well, this is why we should vaccinate pregnant women against influenza. Preeclampsia, Elina Huppinen has already discussed it, so I'll just show this one curve here from Bodnar showing that there's a increased risk of preeclampsia at the lower 25-hydroxy vitamin D levels. Sepsis is another risk factor for, during pregnancy, maternal sepsis. Here's from a paper from Mukherjee et al. In 2007 saying the human cathelicidin LL37, for example, has modest direct antimicrobial activity under physiological conditions, but has been demonstrated to have potent anti-endotoxin activity in animal models, as well as the ability to dissolve certain bacterial infections. Human epidemiological studies support the role of UVB and vitamin D in reducing risk of sepsis. And that's been shown in several studies since this paper here. Okay, I want to say that type 2 diabetes, the risk for type 2 diabetes is linked to low vitamin D and low calcium in this study at Harvard, including a study in Japan and Australia, but a recent study, the one from Australia, said that it was just the vitamin D and not the calcium that played a role. There's a paper by Parker et al. From last year, just sort of a summary of all the studies to date, of observational studies to date, and they found that the highest to lowest 25-hydroxy vitamin D levels in the studies found an odds ratio of 0.57 for developing diabetes. So when we see that women with type 2 diabetes have a less satisfactory pregnancy outcome compared to the general population in terms of perinatal mortality and death within the first month and so on, it seems that vitamin D deficiency played a role in this finding. There's I think I've heard this related to Canada, that have a child lose a tooth. I mean, they're vitamin D deficient in Canada, and the calcium requirements during pregnancy, if there's not adequate vitamin D, can rob the calcium from the bones, and I guess from the teeth, and from the jaw and so on, and so they can lose a tooth. Vitamin D increases calcium absorption, of course, but it also induces production of cathelicidin and defensins, which fight caries-inducing bacteria. I have a paper in press now on the role of vitamin D in reducing dental caries. I've also published a paper with Barbara Boucher on periodontal disease and vitamin D. Here's a paper I found from 1928 from the British Medical Journal, I think from Sheffield. And the woman had done studies with vitamin D in dogs and found that dogs had fewer caries with more vitamin D, and then she applied it to children. And in one of her papers, she said, "It is interesting to note that even in sections of teeth in which caries appears to be completely arrested, the dental tubules may contain microorganisms. These, however, are apparently inactive." In other words, the vitamin D, evidently the cathelicidin killed the bacteria that were giving rise to dental caries. But there's no concept of cathelicidin and killing bacteria then, but the evidence was there and was presented. And so this is one of the benefits of going back to the the old literature and finding these nuggets. So this is an overview of the problems might be related to vitamin D in the UK. Premature delivery, 7%, small for gestational age, low birth weight, rickets, cardiovascular malformations, infant heart failure, and neonatal hypocalcemia and seizures. Plus respiratory infections, sepsis, craniotabes, anemia, type 1 diabetes, schizophrenia, and autism. So I'll go over these just very quickly. A study in Japan found that mothers with threatened premature delivery had significantly lower 25-hydroxyvitamin E levels than mothers with normal delivery. It was be about 26 nanomoles for the ones threatened premature delivery, and about 30 for those with or no, 15, 30, about 37 or so with those, 39 nanomoles for those with normal delivery. Small for gestational age, this found a sort of a U-shaped curve with the minimum 7.5 and 2.1 for lower and higher than 37.5 and 75 nanomoles, and no relationship between this and the risk for black mothers. I comment that the finding for greater than 75 nanomoles is surprising, but there may be explanations for that. Here's a study on cardiovascular malformations in the UK. Those with preterm delivery had more problems than those with normal regular term delivery. Here's infant heart failure. Well, they had low levels of vitamin D if they had heart failure, of course. A study in Turkey found that many of the children with rickets had infectious conditions. Many of them were respiratory tract infections. Craniotabes in Japan found that craniotabes was present in 22% of the neonates, and the highest incidence, and the incidence had obvious seasonal variations, highest in April, May, and lowest in November. At 1 month, 6.9% had elevated intact PTH, and 37% had 25-hydroxyvitamin B less than 25 nanomoles per liter. When separately analyzed according to the method of feeding, 57% of breastfed evidence showed 25-hydroxyvitamin B less than 25 nanomoles per liter, whereas none of the formula mixed fed infants did. So these suggest that craniotabes is normal in normal neonates, is associated with vitamin D deficiency in utero, and the deficiency persists at 1 month in many of them. And I think that the United States, the rate is even higher than 22%. It's not, however, considered a problem, but according to Michael Hollick and Bruce Hollis, it is an indication of vitamin D deficiency. John Cannell is also very much interested in autism. He wrote a hypothesis paper in 2008 outlining the evidence that vitamin D deficiency could be behind the rise of autism. He says, and I'll quote here, "Consumption of vitamin D containing fish during pregnancy reduces autistic symptoms in offspring. Autism is more common in areas of impaired UVB penetration, such as poleward latitudes, urban areas, areas with high air pollution, and areas of high precipitation. Autism is more common in dark-skinned persons, and severe maternal vitamin D deficiency is exceptionally common in the dark-skinned." He's now retired from the hospital and is setting up private practice in part to give free service, free consultation and treatment for children with autism in Southern California. Here's a study from the UK. It's finding a doubling of the odds for being born with increased risk for being conceived during the summer was higher than in spring. And so there's a corresponding increased birth of spring birth. This has been seen pretty much in Europe and indicates a problem of vitamin D deficiency during development. So vitamin D deficiency is common among pregnant women in the UK and elsewhere. There are many important health benefits for vitamin D for both mother and fetus. And based on a review of the literature and hearing the talk this morning, it looks like it actually should be 100 to 110, 120 nanomoles per liter for women and during pregnancy. I've got a project with John Cannell and the Vitamin D Council to develop documentation on approximately 100 vitamin D sensitive health conditions. I've been working on this the past year, and I have now 75 documents. These are documents which look at the evidence that vitamin D plays a role in the risk or mortality, what the mechanism might be, what might be the indications for preventing and treating the disease with vitamin D. In addition, there are patient-friendly summaries. I had to hire a nurse, a retired nurse who's now a technical editor, who had to take my 12th to 14th grade reading level and dumb it down to about 8th or 9th grade reading level for the common man so they could understand it. But this is going online tomorrow at vitamindcouncil.org. So you might look at this and see if your favorite disease is there. Thank you.